it gives me great pleasure to welcome Dr. Azzalini. He's the Director of Complex Coronary Intervention Program at the Virginia Commonwealth University Health Pauli Heart Center, and he's an Associate Professor of Medicine. He graduated from University of Padua in Italy in 2006. He completed his cardiology training and a master's degree in research methodology and a PhD in medicine at the Autonomous University of Barcelona. And then he completed 2 fellowships in interventional cardiology at excellent organizations, Montreal Heart Institute and Mount Sinai Hospital. And before coming to Virginia, he was the co-director of the CTO program at the San Rafael Hospital in Milan, Italy. Great pedigree. He does complex work, CTOs, a lot of atherectomy, mechanical circulatory support. He's very well published, nearly 200 papers, has received multiple awards, and is on the editorial board of major journals like Eurointervention, Cardiovascular Revascularization Medicine, and Angiology. It's my great pleasure to welcome Lorenzo, and he's been working with us on a project looking at the impact of LVEDP in the patients undergoing PCI. Lorenzo, we look forward to your presentation.
Can you hear me? Hello,
Yeah.
Can you hear me?
Yes, I can.
Okay. Thank you very much for the invitation and introduction, Dr. Gurm and members of the BMC2 group. Today, we're going to discuss about a topic that has elicited my curiosity for a long time: left ventricular and diastolic pressure and its role on the outcomes of patients undergoing PCI. So LVEDP has been measured during left heart catheterization for many decades. It represents the pressure in the left ventricle at the end of diastole, when the mitral valve closes and the isovolumetric contraction is about to happen. LVEDP provides invaluable information on the filling conditions and LV compliance, being a marker of diastolic heart failure. It's a highly dynamic parameter that can show instantaneous variations in response to pathophysiologic insults, intravascular volume expansion or depletion, and drugs such as vasodilators and diuretics. As a marker of diastolic heart failure, it can be elevated in many conditions, such as left ventricular hypertrophy, restrictive physiology, aging, and ischemic heart disease. However, LVEDP is also an early marker of acute systolic heart failure. Impairment in the myocardial contractility alters the diastolic pressure-volume relationships and shifts the end diastolic pressure point upward, so that LVEDP can also indirectly provide information on LV systolic function. So here we can see in the top panel that when there is a decrease in the contractility, there is a decrease in stroke volume. And to compensate, the 30 milliliter increase in LV end diastolic volume needed to normalize the venous return and return the stroke volume to the basal level increases LVEDP from 10 to 23 millimeters of mercury. In addition to being a marker of LV performance, LVEDP is also an important determinant of coronary perfusion pressure, which is given by the difference between mean arterial pressure and LVEDP. So if LVEDP increases, the coronary perfusion will be impaired. This makes it particularly pertinent to patients undergoing PCI because repeated ballooning, stenting, or atherectomy can independently worsen myocardial perfusion, thus potentiating this vicious circle. Therefore, high LVEDP may hamper this patient's ability to tolerate temporary ischemia during PCI. Our study aim was therefore to evaluate the association of LVEDP within hospital outcomes in a large cohort of unselected patients undergoing PCI for elective or urgent indication in BMC2 registry. And we decided to focus on elective and urgent indications because there is already ample literature on the association of LVEDP and outcomes in STEMI. And as we will see in the discussion, there is some controversial data for ACS, but no study to our knowledge has investigated the association of LVEDP and outcomes in patients undergoing PCI for elective indications. So between April 2018 and June 2021, we screened over 93,000 patients, and we excluded approximately 18% of patients because they presented with either a STEMI or other emergent or salvage PCI indication or cardiogenic shock. We initially identified a cohort of 76,200 patients undergoing elective or urgent PCI, and we then excluded 34.9% because they did not have LVEDP measurement available. So the actual study population was represented by 49,600 patients undergoing elective or urgent PCI. This population was divided in tertiles of LVEDP. The first tertile was less than 13, 18,000 patients, then second tertile between 13 and 18, 15,000 patients, and LVEDP of greater than 18 millimeters of mercury was identified in 16,000 patients. If we have a look at the baseline clinical characteristics of this population, we will see a consistent pattern across increasing LVEDP tertile. So patients with progressively higher LVEDP, and particularly patients with LVEDP of greater than 18 millimeters of mercury, had higher body mass index, a higher prevalence of female sex, higher prevalence of African Americans, and in general, slightly, or according to the variable, even moderately higher prevalence of cardiovascular risk factor and conditions, in particular, diabetes mellitus, prior PCI, prior CABG, PAD, cerebrovascular disease, importantly, chronic heart failure, which was 12 to 14 percentage point higher in this group, atrial fibrillation, and this patient also had lower eGFR, lower hemoglobin, and a longer in-hospital length of stay after PCI. LVF was lower in patients with high LVEDP, and the prevalence of patients with LVF of 35% or lower was particularly higher in this group. Also, presentation with non-ST elevation ACS was higher in this group, and cardiovascular instability was higher as well. So summarizing these first couple of tables, patient in the high LVEDP tertile had a larger body habitus, higher prevalence of female Black, cardiovascular risk factors and comorbidities, particularly heart failure and LV dysfunction, and more frequent presentation with non-ST elevation ACS and cardiovascular instability, and they stayed in the hospital for longer after PCI. Similarly, when we have a look at angiographic and procedural characteristics, we can see that this patient population in the high LVEDP tertile had more complex angiographic presentation and procedures. So higher use of the femoral axis compared to the radial axis in this high LVEDP cohort, higher prevalence of multivessel disease and multivessel PCI, left main PCI, need for mechanical circulatory support, and atherectomy. This is also mirrored by worse procedural metrics such as fluoroscopy time and contrast volume that were higher in the high LVEDP cohort. And also technical and procedural success were lower in this patient group. So summarizing again, patient in high LVEDP tertile, higher CD burden, more complex procedures, and lower success rates. Let's have a look in hospital outcomes. Patients in LVEDP more than 18 millimeters of mercury group had higher incidence of all complication and adverse outcomes except for myocardial infarction and major bleeding. So much higher incidence of heart failure, higher incidence of cardiogenic shock, acute kidney injuries was almost triple compared to the low LVEDP cohort. Even new requirement for dialysis was higher in this group, although the numbers are very low still. And importantly, the primary outcome of our study in hospital death was twice as frequent in this patient group. This is the illustration depicting in hospital death rates across the three groups: 0.3 in the lowest LVEDP cohort, 0.45 in the mid one, and 0.8 in the high LVEDP group. So we therefore wanted to identify the optimal LVEDP cutoff to identify a cohort at particularly higher risk of a death and other complications. So this is actually a very high LVEDP cohort. So we took all our population and we iteratively dichotomized the data set according to LVEDP. So we created many groups according to LVEDP, either greater than or equal to the proposed cutoff or lower than that cutoff. And for each cut point, we constructed a 2x2 contingency table, and we calculated the Pearson chi-square test. So the cutoff was ultimately identified as the value of LVEDP with the highest Pearson chi-square test. And this is a pictorial representation of these. And we can see that between 25 and 27, we have the highest value for the chi-square, and the actual optimal cutoff is 26 millimeters of mercury. So then we proceeded further analysis according to this optimal cutoff. And the results are even more marked than what we've seen in the LVEDP greater than 80 millimeters of mercury cohort. So patients with LVEDP of 26 millimeters of mercury or higher had more than triple rate of in-hospital death, almost fourfold higher AKI risk, and even other in-hospital adverse events such as new need for dialysis, heart failure, cardiogenic shock were markedly higher in this group. And then when we had a look at in-hospital length of stay after PCI, we noticed that there was an excess full day in hospital stay from 1.4 to 2.3 in the mean hospital stay in this higher LVEDP cohort. When we then performed multivariable analysis and we evaluated the adjusted impact of LVEDP of 26 millimeters of mercury or higher on in-hospital outcomes, we saw that there was a twofold higher risk of adjusted risk, actually, of in-hospital mortality and post-procedural heart failure in this patient group. And also this condition increased the risk of AKI by approximately 66%. And the post-procedural length of stay was increased of an average of half of a day in this high LVEDP cohort. Finally, we wanted to perform another analysis to actually provide the clinician with a decision-making tool to risk stratify their patients. And this was a recursive partitioning tree model. Analysis were performed as usual by Milan Seth, and this is our partitioning tree model. So we just took patients undergoing elective PCI with LVEDP of 26 millimeters of mercury or greater. We had more than 5,000 of these patients, and the mortality rate was 1.5%. With 5 commonly measured parameters, namely hemoglobin, systolic blood pressure, estimated glomerular filtration rate, atrial fibrillation, and left ventricular ejection fraction, we were able to risk stratify our patients. We observed mortality rates between 0.5% in patients presenting with hemoglobin of 10.5% or greater, systolic blood pressure of 128 millimeters of mercury or greater, and EGFR of 28 millimeters of 28 or greater that had a mortality of 0.5%, all the way to a mortality rate of 10.4 in patients with hemoglobin less than 8.8 and LVF less than 48%. And so we can see that except for these 3 groups, all the other groups had a much higher mortality rate than the mean for this patient population. And if we consider that the average mortality in an NCDR for PCI in all comers is approximately 2%, that includes also cardiogenic shock and ACS, we can see that this patient group have a very high mortality rate, especially for elective PCI. So summarizing, our main findings were that 1/3 of patients undergoing elective PCI or urgent PCI have an LVEDP of greater than 80 millimeters of mercury. This identifies a higher risk cohort in terms of baseline clinical characteristics and presentation and angiographic and procedural variables. Patients across increasing LVEDP tertiles suffer higher rates of in-hospital adverse events, including death, whose incidence was more than 2-fold higher in patients with LVEDP greater than 18. LVEDP was an independent predictor of several key clinical outcomes, and we estimated that there was an adjusted risk increase of 25% of mortality per 10 millimeter of mercury increase in LVEDP. And patients with an LVEDP of greater than 26 or equal to 26 undergoing elective PCI had markedly higher mortality rates, up to 10.4%, according to a clinical profile defined by 5 commonly measured variables. What are the mechanisms that can explain this association? So we've seen in the introduction that the myocardial perfusion is driven by the diastolic pressure gradient between the aortic pressure and the LV pressures. So high LVEDP leads to decreased coronary perfusion pressure. This will decrease the microvascular flow and oxygen delivery, and will trigger all the classic mechanisms of both acute and chronic heart failure, such as sympathetic and neurohormonal activation and myocardial remodeling. There have been also a couple studies hinting of a possible association between higher LVEDP values and the risk of developing AKI after PCI, because volume overload can hamper and impair venous drainage from the renal vein. So there is a higher renal venous pressure that can lead to an increased risk of AKI in this patient. And of course, ballooning, atherectomy, and stenting during PCI can further increase LVEDP and worsen myocardial perfusion. So our recursive partitioning tree model provided a very valid decision-making tool for the clinician, identifying patient categories that have an acceptably high rate of mortality after elective PCI, basically patients with severe anemia, atrial fibrillation, and lower systolic blood pressure, LVF, and eGFR. So we think that perhaps this patient can benefit from medical optimization or even possibly mechanical circulatory support in appropriate cases. So concluding, elevated LVEDP is observed in 1/3 of patients undergoing elective or urgent PCIs associated with increased rate of in-hospital adverse events, particularly death. Patient with very high LVEDP equal to or greater than 26 millimeter of mercury undergoing an elective PCI had higher adjusted risk of mortality, AKI, heart failure after PCI, and longer length of stay after PCI. And we think that such patients, especially those with high-risk feature that require aggressive procedure and techniques such as atherectomy and left main PCI, for example, might benefit from further clinical stabilization and medical optimization prior to PCI. Thank you very much for your attention. Open to questions.
Thank you so much, Lorenzo. That was a fabulous presentation, and data that obviously have great implications for our practice. I welcome comments from our colleagues.
Thank you.
Sorry, can you hold on 1 second? Mansoor raised his hand. So Mansoor, go ahead, please.
Yes, hi, good evening, and thank you so much for this presentation. It's very helpful. Is there a cutoff that you would recommend where you could cancel the procedure and just not proceed? Because 20 above 18 or even above 25, we see it not too infrequently, and patients are there and you have to proceed a lot of times. But is there a cutoff that you would say, well, just don't do it?
Yeah, thanks for your question. Okay.
Yeah, sorry, that's a really good question. And, Lorenzo, I would love to hear your thoughts, but then maybe we can ask some of the other colleagues on the group. Because, one group that is not present in these data are patients whose procedure was canceled, right? So we don't know at what level people are canceling. So Lorenzo, please go ahead.
Yes, no, it's a super valid question. Actually, in my experience, and also since some case reporting literature, some case presentation at conferences, even if you put an impella in a patient with an LVEDP of 45 millimeters of mercury, for example, you will create so much strain on this already overloaded heart that then, even if the procedure is successful and the hemodynamics are somehow maintained, you might not be able to actually discharge a patient easily. Maybe the patient even gets into pulmonary edema and you need to intubate the patient because the impella can help up to a certain extent. So I do believe that, with LVEDPs of, for sure above 40, I would say even 35 perhaps, for elective or semi-elective procedure, we should definitely postpone the procedure until we are able to medically optimize the patient. And at some point, it's very hard to decide whether or not, if we're not able to compensate the patient further, if we should directly cancel the procedure altogether. But for sure, we have to be aware that with LVEDP of 40 or 45, the patient is going to be crashing, at least under the respiratory point of view, even if we use an MCS.
So I saw a hand from Dr. Reddy.
Yes, question is, was there any concomitant valvular heart disease? And if so, did that have any bearing on the LVEDP and hence the mortality also?
Well, I think the proportion of patients with significant valve disease was negligible in this cohort. It was, I think, something we looked at when we were polishing the data set initially, but it was really a negligible proportion of patients. So like, for example, severe AS or severe MR.
Okay, thank you.
Dr. Lauer?
Yeah, excellent presentation, and brings up some good points. Just kind of follow up on your last question and response. Are you aware of any programs that have instituted and or published deferring intervention for some intervention and bringing back? I mean, that would be the next logical step. I mean, obviously the sicker people do worse, and somewhat in the argument that we've always had with surgeons is they're not going to take the the VSD patient for 3 weeks, because then you self-select everybody. But it'd be interesting if you find those people in those high-risk subgroups, maybe bring their hemoglobin up, which is one thing that we've actually done to try to reduce bleeding complications and negative outcomes. And that was one subset. If you stop those people with the hemoglobin 10.5, or also whether perhaps you adjust your calculated maximum contrast use, because the higher the EDP, the less they would tolerate, perhaps. I don't know if you know of any efforts or published data on those strategies.
Yeah, those are good points for sure. For the problem with observational data is that there are a lot of confounders. So in fact, the group with higher LVEDP also had a more complex lesion and higher contrast volume, and this for sure does not help lowering the risk of AKI in this patient population. I think the first thing is to come up with some big data analysis like ours, and then this will stimulate all sorts of research question that can lay the foundation for a randomized controlled trial for a very specific question. But after analyzing this data and this experience with your group, that is amazing for me. I think I will look much more carefully than even before. I was already attentive to LVEDP, but these data, patient with LVEDP of greater than 26 undergoing elective PCI, we should definitely try to compensate them more, even if we're doing just something that can be perceived like a bread and butter, like a bifurcation PCI, because at the end of the day, we're going to occlude the main vessel, the side branch, many times, and these patients might maybe they do fine on the table, but then they get an adverse outcomes later on during the hospital stay.
So if I may add to that, our practice at Michigan mostly, and I'll say mostly because not everybody always did that, but most of my colleagues, if the EDP is more than 30, unless it's a clinical emergency, we tend to defer. Like you get the patient's heart failure optimized, get them diuresed, and then bring them back with the plan that if the EDP is still higher, then you move towards mechanical support, unless the PCI is very simple. So the complexity of the procedure also plays a role. And I would love to hear from Dr. Berman.
Oh, thanks. I enjoyed also your talk very much. Thank you. I presume that the LVEDP measurements that you measured were before any medical intervention, such as giving some intravenous or intraventricular nitroglycerin or other medications. And how would you view someone with an LVEDP of 25 who dropped, maybe they were hypertensive or so, and that they dropped into the low teens after some acute medical therapy?
Yeah, that's the beauty and a great limitation of observational data. We absolutely have no information on when LVEDP was measured during the procedure, if medication were given before or after. Also, we did not have a core lab adjudication on the actual hemodynamic tracing of LVEDP. So these are all limitations to be taken into consideration, and this is why our findings can be considered hypothesis generating. Unfortunately, we do not have like a prospective protocol where all these questions that you mentioned and I mentioned can be actually answered properly.
Thank you.
Dr. Arora?
Thank you. It was a wonderful presentation. I was wondering, do we have to do LVEDP measurement with the invasive work only, or if the patient had an echocardiogram and looking into diastolic dysfunction could shed some light? And the other question was if the surgical revascularization show the same issue, or do we need to look into more detail for the surgical patients or surgical revascularization?
So we do not have a correlation with echocardiographic variables, and we know that there are echocardiographic parameter E first ratio that can approximate an estimation of LVEDP, but as far as I know, you cannot precisely estimate the LVEDP, the exact value with echocardiogram. LVEDP measurement during coronary angiogram and left heart cath is so commonplace that I think that's a very easy thing to do for the interventional cardiologist. And with regards to surgical revascularization, I mean, I don't think there's any data on hemodynamic parameters just before surgery for CABG. And I think that anyway, these conversation we had about PCI and adverse outcomes should also be undertaken when we approach surgical revascularization, because the surgery is a great stressor for the patients. So if you send a patient to the OR with an LVEDP of 30 to 35, I don't have data to support my claim, but I am confident that the rate of post-operative complication will also be higher.
So, I saw Khaldun, you had your hand up. I'd love to hear your thoughts.
Yeah, so sorry, I can actually, most of the wonderful comments kind of answered part of my question. The thing about it, which is I'm always kind of troubled by it, we really don't know which strategy to do when LVEDP is high. And honestly, a lot of times the patient goes and their LVEDP doesn't get better. And I've seen a lot of those patients. And no diuresis, and I'm not sure deferring the procedure, is there any data that shows deferring the procedure makes any difference? At the end of the day, those patients have a bad prognosis regardless, or they have worse prognosis regardless of. So I am always troubled by these findings, severe LVEDP. The other thing, which is also, I'm not sure how many of us measure LVEDP routinely, so I don't know the number of that. For one, if a catheter goes in, I measure it. If it doesn't, I just depend on the echo findings to decide. So it's really, the question is much more complex, and we probably ought to do it prospectively to answer these questions.
Hey, Carl. Nice
hey, how you doing? Great to see you.
Hey, great to talk to you. I can hear you only, but yeah, you made a great point. We don't know if it's like high LVEDP is just a marker of a higher risk profile of the patient, or if it's an actionable parameter. Maybe I'm sure up to a certain extent you can compensate the patient, but who knows if you can bring down an LVEDP of 40 to maybe 18 and do the procedure safely, So it's a good point. It's an excellent question for a prospective, ideally randomized clinical trial.
So
anyway, 35%, only 35% of patients in this cohort did not have an LVEDP available. So I mean, I would say that 2/3 of patients have an LVEDP before the PCI.
Right. So I think, also, one thing that I do want to point out, that most patients, even with the high EDP, had a good outcome. So it's not that simply EDP more than 26 should be deciding not to do a procedure or to do a procedure. But the way I think about it is, it's the complexity of the procedure. What else does the patient have? And we recognize these data have not been peer-reviewed, published yet, but they will be shortly. But like a patient who has anemia, low GFR, and low EF, and has atrial fibrillation, their risk is much higher than somebody who has a normal GFR and is not anemic. And there were a significant number of patients with low EF who had a fairly low or a normal EDP. So I think the complexity of the procedure also plays a role. Is this something where you're going to be working on an OM, or are you going to be working on doing a complex left main? So I think all those factors play a role. But our hope is that this will help at least guide us as we collect these data. We will learn more, and then we'll be able to come up with some guidance as to how we should be using these data to how people are changing practice, and what is the best practice. Eddie, I'd love to hear your thoughts on this.
Yeah, hi, thanks a lot. I just actually sent the message just in interest of time. I really think a great presentation, and thank you for the observation. But I also had like the same opinion as Cal. I wonder how prospectively this thing, because it looks like, I mean, obviously that it's a measure that's associated with worse outcome, but I also think maybe a lot of it has to do with all the risk factors that these patients have. You know, they're more obese, they're have hypertension, other risk factors. So I think that will only be sorted out once we do it in a prospective fashion. But as you mentioned, a quick note, I think Cal mentioned, measuring LVEDP. We try to measure it in all the patient per year recommendation and BNC squared in terms of CIN prevention and hydration post and using Poseidon protocol. So we try to encourage all the interventional guys to do an LVEDP pre-PCI.
So, Dr. Shah had a comment related to use of intra-aortic balloon pump in patients with elevated EDP and undergoing PCI. I think depending on the complexity of the PCI, that definitely helps. The EDP definitely comes down with the use of mechanical support. There's no doubt about that. And Mike had a question about, do we often see the LVEDP come down when deferred? I would say it's about 50-50. I can't say it's 100% of the cases, but in a significant number, we are able to bring the EDP down with appropriate diuresis and getting them on afterload reduction and so on.